There will be Q&A at the end, or you can type your question in the chat room at any time during the presentation, and we'll make sure to get to those. We're recording. We will be re-showing this for our virtual speaker series the third Wednesday in October at 6 p.m. Also to a group of UWM clinical mental health nursing students who are also working virtually with us. So without further ado, I would like to introduce Dr. Jamie Roberts. And Dr. Roberts is a licensed psychologist in Wisconsin. She currently serves as clinical services supervisor for mental health recovery programs, OCD and anxiety programs at Rogers Behavioral Health. And I will pass it over to Jamie now to do her presentation and add on to any introductory comments that you'd like to, Dr. Roberts.
Thank you. I think you actually covered everything. I have that kind of outlined here, and I think you hit on all of those points. So thank you for that introduction, and I'm happy to be here today supporting NAMI and our partnership with Rogers. So I'm going to jump right in because I do have quite a bit of content to cover. So my plan for today is to talk more about depression and how it relates to treatment as far as the use of behavioral activation goes. So we're going to talk about just kind of a brief overview of depression, the theory of behavior activation, the various components that comprise behavior activation, and then how to go through and actually teach behavior activation to patients that you may be working with as a provider. As well as kind of going through how we teach behavior activation in our setting at Rogers. So just to start, I will go through kind of a brief overview of major depressive disorder. I'm sure most people are relatively familiar with the diagnostic criteria, but just again, as a refresher, so to meet criteria, according to the DSM-5, an individual has to show at least 5 of the following symptoms, which need to be present during the same 2-week period. And at least one of those symptoms does need to be one of those first 2 items that are bolded. So either a depressed mood, which could be irritability for children and adolescents, or a diminished interest or loss of pleasure in activities. So they have to have at least one of those in addition to other symptoms in order to meet that criteria. And those could include things like significant changes in their weight or a disturbance in their appetite, some type of sleep disturbance, restless sleep, not getting as much sleep or sleeping too much, psychomotor agitation or retardation, so change in how they're physically presenting, fatigue or loss of energy, feelings of worthlessness or hopelessness, a change in their ability to think or concentrate, and typically a reduction in that, as well as potentially recurrent thoughts of death, possibly suicidal ideation. And that could be more passive suicidal ideation, or it could be more active, where individuals are actually coming up with plans or making attempts to engage in suicidal behavior. And collectively, those symptoms need to kind of relate to some level of significant distress or some impairment in their functioning within settings that apply to them. So potentially within their social settings, occupational, or academic, for example. Just to go over some prevalence rates of depression, in looking at adults and youth, we see that depression rates are quite high, and this data is taken from the National Institute of Mental Health for the most recent survey data that's available, which is from 2017. I imagine that we'll see some shifts in those prevalence rates with everything that's going on in the world today when they do an updated survey. But for now, this is the most recent data. And that outlines that for adults, there are 17.3 million US adults that have had at least one major depressive episode. And that accounts for about 7.1% of all US adults. So flipping over to adolescents or youth between the ages of 12 and 17 in the United States, there was 2.3 million who had at least one major depressive episode that qualified for a severe impairment. And that's about 9.4% of the US population. For both groups, we see that rates are higher among females compared to males. So in adults, about 8.7% of females compared to 5.3% of males. And the discrepancy is a little bit larger for adolescents, with females demonstrating 20% compared to males at 6.8%. Again, consistently across adults and youth, we tend to see higher rates of depression for individuals who report to have 2 or more races. And then for adults, we also tend to see higher rates in a specific age range between 18 and 25 versus the older adult population. So I think we are all in agreement that depression is a problem. It's highly prevalent in our communities and in the individuals that we work with. And so, the reason that people generally attend these webinars and these talks about how to address the depression is because you want to know what to do when the patient's sitting in front of you. And that's why I will be going through in a lot of detail behavior activation today. Some of you may have heard of behavioral activation, some of you may not. Most of you have probably heard of CBT, or cognitive behavioral therapy. And behavioral activation is actually a component of cognitive therapy, and we'll go through the history on that a little bit. So it's truly not a new idea, and has generally always been in cognitive therapy in some form or another. The premise of behavioral activation is that it works to assist individuals in accessing more reinforcing experiences, kind of with the idea that they may be avoiding those experiences when they're depressed. The theory really looks more at the importance of the context. So kind of what is the individual doing, as opposed to how we typically think of cognitive theory, which is more focused on feelings or thoughts. So we really look at that link between the behavior and the environment versus that emphasis on thoughts and feelings. That's still included in the treatment, but it's just not as emphasized as the behavior. So there has been many well-established thorough meta-analyses to validate the empirical stance of behavior activation. There have been many randomized control studies, and overall behavioral activation is seen as a very well-established, empirically validated form of treatment. A number of studies have found that behavior activation actually leads to better outcomes than control conditions, and either similar or better outcomes when compared to other established treatments. And most of the established treatments that are utilized in the comparison research is to cognitive therapy, or CBT. There's also been a lot of research more recently devoted to using behavioral activation with adolescents. And Macaulay and colleagues have done more of the recent research in developing some manuals that are finding some very positive outcomes. And that's an area that that's continuing to be studied as well. The research also shows that behavior activation might be more cost effective and easier to disseminate than CBT. And so it's generally seen as kind of a fairly simple concept and intervention. Of course, it does have its nuances and specifics that require use in order to make it as effective as it can be. But there's some thought that CBT can be fairly complicated at times. It can require pretty extensive training. There's a lot of abstract ideas with it, which can be somewhat challenging to teach to patients and to clinicians. And so the idea is that if we're using a more straightforward approach that's a little bit easier to train individuals on, that easier training can lead to more individuals who can provide that treatment and ultimately serving more patients then. So looking at the theory of behavioral activation, this really goes back to the 70s. And there's, with this focus on the balance between avoidance and response contingent positive reinforcement, which is that RCPR on the right there. So response contingent positive reinforcement really just focuses on this need to increase the amount of available reinforcement in the environment, while also on the other side decreasing the avoidance. So to give a little bit more emphasis to the response contingent positive reinforcement, the idea is that there's 3 factors for individuals who are generally depressed, and we can address that by increasing and looking at the function of their opportunities. So how many potentially reinforcing events does the individual have in their lives or in their current context? Their access, so how available are the reinforcements in their environment, and then the skill, do they have the ability to obtain those available reinforcers? So for example, if you have an individual who is somewhat motivated or reinforced by social engagement, they enjoy interacting with others, but have been avoiding that task, we would want to assess that idea with looking at, do they have the opportunity to access social interactions? Are they attending school? Are they involved in any groups or extracurriculars? Do they have access to those things, those individuals, let's say, the social kind of interaction? So maybe they are attending school or they're involved in extracurriculars, but the individuals that they want to associate with or socialize with are not involved in those, and they're involved in different group activities that would limit their access. And then do they have the skills? So this is kind of looking at, they're interested in being social, but are they perhaps a little deficient in their social skills? Are they challenged in being able to reach out to somebody or to maintain communication with an individual? So that response contingent positive reinforcement, understanding the function of that, allows us points of intervention to hopefully increase those opportunities. On the flip side, we know that avoidance is something that many individuals with depression engage in. And the kicker with avoidance is that, we recognize that it provides this short-term relief that feels kind of good in the moment to avoid the things that we don't want to do or that are unpleasant. But we know that too much avoidance actually leads to maintaining and worsening depressive symptoms. So, and the goal then of behavioral activation is to really balance those two out. So we would look to increase the available reinforcers in the environment while simultaneously decreasing avoidance over time. And the overtime piece is kind of critical, which we'll come back to. So to go through a little bit of the history of behavior activation, there has been a progression in the models over time, as I said, starting back into the 70s. So it started with pleasant event scheduling. And this was really focused more so on just identifying things that patients enjoyed and having them do more of them. So that was kind of this original idea of accessing those reinforcers in the environment. We then saw some development in the 70s still again of Beck's cognitive theory. And this had activity scheduling as part of that original cognitive theory. From there, and kind of a framework for some build off of behavior activation was Jacobson's component analysis. And in this research, Neil Jacobson and his colleagues actually looked at comparing 3 different treatments. And so they had 3 groups. The first group was just given activity scheduling, or what Jacobson called behavioral activation. The second group participated in activity scheduling along with cognitive restructuring. So looking at automatic negative thoughts and giving some focus to the restructuring. And then the third group actually did what's considered kind of the full CBT package, where they participated in activity scheduling, the cognitive therapy of the restructuring, as well as modification of their core beliefs. And what they actually found from that analysis was fairly surprising in that all 3 of those groups performed equivalently. So where previously there was focus on, this kind of more is better, let's do it all, Jacobson kind of concluded that, why would we do something that's more complicated in having all of those other elements that are a lot more challenging to train, a lot more challenging to explain to a patient, when we can do one and have the same outcome. And so it was really about kind of paring down the tasks and the interventions, and still seeing those great outcomes that come along with, you know, what we generally consider for cognitive therapy. So that analysis really kind of led to this breaking away of behavioral activation. As you all know, likely, you know, cognitive therapy is still around and still done with regularity. But for depression, it has been found that behavioral activation is just as effective. So Martel and his colleagues developed a standalone behavioral activation manual in the early 2000s in order to kind of give some direction about how to implement behavioral activation. Carl Lejeune and his colleagues also looked at behavioral activation treatment for depression with an additional manual, and adding in some other elements as well. And then there was kind of this focus on stepped behavioral activation, which was basically using activity scheduling and also adding in this piece of a hierarchy, which we'll talk about in a little bit more detail. So to go over some of the basics of behavioral activation, now that there's more of kind of a foundational understanding of the theory. The basics of behavioral activation are really looking at the life circumstances of the individual as causal, rather than focusing on individual deficiencies. So while there's some, you know, theories that kind of look at the individual or reinforce this idea that there's maybe something internally wrong with the person, behavioral activation really focuses more so on those external factors, the events in their life. So again, you know, even with cognitive therapy, it may be more focused on how the individual is thinking in a distorted way. Can you guys still see my screen? It just kind of glitched on my end.
Yes.
Okay, thank you. So I think I was saying that the individual may be discussing with their therapist or their clinician about their distorted way of thinking, or kind of seeing it as like maladaptive. So sometimes the way that they're thinking or feeling is framed in a negative light, or there's something wrong with your brain or your chemical makeup. Those are things that people can internalize, and behavioral activation, again, really tries to take the focus off of that, in evaluating more so the events in the individual's life and how they're responding to those events once they become depressed. So it looks more at their behavior, and seeing that their behavior is often a function of something else. So generally avoidance, as I mentioned, is evident in depressive individuals. So we see a lot of things like inactivity and withdrawal, isolation, and we would want to look at what factors are leading to that type of behavioral presentation. We know that avoidance limits opportunities to access reinforcement. You know, going back to my example before about somebody being reinforced by social interaction, you know, if they're isolating and they're withdrawn and not leaving their home, that clearly limits their ability to engage in that social interaction. If they're refusing to charge their phone and their phone is consistently dead, they're not able to reach out to those individuals and engage in that communication with them. And so we know that when they're avoiding these opportunities for reinforcement, we see secondary problems develop. So maybe they once did have friends, but now those friends have kind of discontinued contact with the individual, or no longer really interested in maintaining that relationship. And so you see secondary problems develop from that, of now they're getting no social interaction, or now they're not leaving their home, or maybe those friends were in a work setting or a school setting, and so they start to avoid that, and their grades are declining, or their job functioning is impacted. So we kind of see this loop begin to develop, and in our wording we call it a trap, which I'll go over, but it really kind of facilitates just that cycle of depression and being stuck with that. So behavioral activation really looks at targeting those escape and avoidance behaviors through activity scheduling to reduce and eliminate that cycle. So the components of a behavioral activation program are generally consistent with other, theoretical orientations. In that we look to first develop, a therapeutic relationship or a rapport with the individual. There is some heavy emphasis for behavioral activation on presenting the model right away for an individual. So the first session, within the first session, we should be discussing behavioral activation and providing some psychoeducation on what behavioral activation is, what it looks like. We should be encouraging questions on the part of the patient to get that engagement and that back and forth and that investment in their treatment. And it's also really helpful to provide some written resources for what behavioral activation entails so that the individual has an opportunity to read over those materials, hear it again, bring that content back into the therapy sessions as we're big on repetition and practice of skills. So we commonly will send individuals home with materials where they can actually reference what we're going over in those sessions or in those groups. Development of treatment goals, again, pretty consistent with most treatment methodologies. So we definitely want to develop treatment goals and have the patient be a part of that. We, in behavioral activation, continue that focus with short-term goals and long-term goals that relate to the circumstances that kind of precede or maintain their depression. So that's where, again, we're looking at the behaviors. So what can they do differently rather than looking at feeling good or thinking differently. Those are much less attainable to tell somebody just think in a different way or just feel a different emotion. And when those are the goals that are set, they can feel really challenging to meet if an individual feels they have a little control over that. So again, we really shift that focus back to something that is specific, measurable, attainable, realistic, and time-bound, which is our SMART goals, but really more so, again, focused on that behavioral piece. And we can get at the behaviors a little bit more by doing a functional analysis. So in order to conduct a functional analysis, it's a straightforward process of just asking questions, which is, again, consistent with many other theoretical orientations. We're asking a lot about their circumstances, what happens in their environment, how they respond, getting a better assessment of their triggers, what happens after they're triggered, what types of symptoms do they experience, how do they respond to those triggers or those emotions? Again, are they avoiding, or are there some situations where they are actively coping? Are there some times where they're coping better when others are supporting them? So really going through and being pretty detailed in your analysis of what is happening, as well as focusing on what has become disrupted because of these things. So looking at their routine is a really important first starting point that we intervene with. And then the last component would be focused more so on relapse prevention. So what we want to do, since we know there's such a high rate of relapse with depression, is be very intentional about teaching patients how to independently engage in functional analysis. So we want them to be able to do this without us. We want them to encounter a situation and look at, what triggered me in this circumstance. What was going on in my environment when I felt that I noticed my depression increase, or I noticed an increase in symptoms. How did I respond to that? Did I actively cope, and what did that do for the situation, or did I avoid, and how did that impact my mood and the subsequent responses? So again, it's really important to get their investment with that and their understanding that we are here to help give them the tools, and we want them to be able to utilize them with some level of independence. Built off of that functional analysis, we also want to develop a response plan, and that's something that we obviously do with them and support them with as well. But we want them to develop a plan to actively cope. with that recognition that when they're depressed, they're more likely to avoid. And so they certainly need that support to learn more about active coping. So we want them to have that plan built out, but also be able to assess the plan and be able to update it as necessary once they're either no longer in treatment or maybe once they're at a point where they're more so maintaining their progress. So you've heard me talk a lot about behavioral activation and these activation strategies or activity scheduling. So I'm going to go into a little bit more of the activation strategies that we utilize with our patients and that you can also utilize with yours. So focused activation is one, and this is kind of based off of the idea that our interventions are focused very specifically on activation assignments. As I was speaking about before with functional analysis, that's going to be very different for every individual. So we want to know their specific triggers, their specific responses, because what that does is it allows us to develop a very specific means of intervention. We are not doing kind of generally pleasant activities when we're assigning tasks for them. And so allowing that specificity increases the activities based on that functional analysis rather than just this kind of like broad understanding. We can generally say that most people might like fresh air or might like going for a walk. But if we assign that as an activation assignment for every single person, you're likely going to get some people that really just don't find that interesting or enjoyable. And so again, we want to operate more so on an individual level about what that particular person finds reinforcing. And we do that in a couple of ways. So we start with activity monitoring. And this is really kind of like our first step in gaining that better understanding and that functional assessment of what the individual is currently doing. So it helps us learn, how are they currently functioning? What does their routine look like? What is their schedule? And they might not even have one, but it at least gives us a breakdown of what their behaviors are on a daily basis. From there, we can start to develop some aspects of activity scheduling, and we do that by honing in on 3 different categories. So we look at their routine activities, so kind of the things we do on a daily basis, waking up, brushing our teeth, taking a shower, making our bed, eating breakfast. So those routine things that we're all just kind of used to doing on a daily basis. We also look at their pleasant and enjoyable activities. So things that they find some level of enjoyment from or make them feel a little bit less depressed. These are things like hobbies and recreation. It's important to distinguish the enjoyable activities that are not avoidance, and we'll talk about that in a bit. Excuse me. And then we also focus on valued activities. So what are some activities that actually are in line with their personal values and things that they find really important? So we gauge the activity scheduling based on these areas. And it's very helpful to get individuals started right away with activation assignments while we continue to assess. It's unreasonable to expect that somebody is going to outline all of their values in the first session with them. So we really kind of start with that routine assessment to better form a schedule to kind of get them started and then build off of it from there throughout the assessment process. Excuse me. Graded task assignment is the next strategy that can be utilized. And this is really focused on assigning tasks in a broken down manner with the recognition that we want to start with kind of the easier tasks and move into more challenging areas. As we know with individuals with depression, their motivation is typically low. They feel overwhelmed by even small things. And so it would not be in our best interest to just throw all of these tasks at them or these really difficult feeling, unachievable tasks and expect them to actually complete them. So we want to break these things down. We want to explain that they're derived from our functional analysis. So again, kind of going back to their specific needs. And then we also really want to validate at this point the difficulty of starting new behaviors, and breaking them down and putting them in a graded task assignment is actually validation in and of itself, that, you know, we are not expecting you, if you've been unemployed for a long time, to get a job tomorrow. That is not the idea. If you've been avoiding school and, you know, you have 20 or more days of tardies, we're not expecting you to go every single day in the first week. Eventually those expectations may come, and it's important to outline those. But what's more important and more validating is recognizing that we are going to start small and build our way up. Another strategy to build in with graded task assignments is to mentally rehearse any obstacles. So this kind of gives the individual a way of saying, you know, your long-term goal is that you want to get that job back. What are some obstacles that you see getting in your way? It could be something as simple as not having access to technology in order to look online for jobs. Or if it's, you know, attending school, it could be something related to transportation. It could be smaller things that are just kind of like, I don't have the clothes that make me feel confident enough to go to school. You know, there's a slew of specifics that could come into play here, and going through and kind of mentally rehearsing following through with those tasks is a great way to help identify those obstacles early on, so that we can prepare for those rather than putting somebody in a situation where they have to figure those out in the moment. And what we do with graded task assignment is organize these along an activity hierarchy. So a hierarchy is basically breaking down these tasks into, again, those more achievable pieces and that are building off of each other. And our activity hierarchy allows us to kind of outline that more clearly and show the progress that they're making on those steps. So when we're building a hierarchy, and I'll give you an example of one in the next slide, it's important to assess which items you're choosing. Again, here we are doing this through very specific questions to the patient, assessing their individual experiences in order to develop this. There should not really be any two hierarchies that are exactly the same. There is not kind of a general set of items that are included in there. It does kind of go back to those three categories that I mentioned before. You know, so routine activities, enjoyable activities, and valued activities. But that's about as kind of like set as it is. Within those three categories, they really should be individualized. And we do that again by talking through and asking them these questions about things they are avoiding. You know, what did they used to do before they were depressed, which might give you an assessment of some of their enjoyable activities that they've stopped doing. What does their routine look like? What did it used to look like before they were depressed? Were they a morning person? They were always up early and now they're sleeping until noon. You know, that gives you kind of a starting point. So going through again and getting these very specific pieces through just those conversations with your patient, as well as some forms. We're big on having patients write things down and get it down on paper to kind of outline those ideas and have something to bring back to session. So this is an example of an activity hierarchy, a very small example. Generally, our full hierarchies can be anywhere from 50 to 100 or more items. But what you do see, and what this example provides, is a clear outline of this graduated approach. So for example, if an individual is sleeping until noon, you know, and their goal is to be able to get up earlier to start to set a better routine for their day, we might start with assessing, you know, how would you feel about getting out of bed at 9:30? And if the patient rates that that's a difficulty of, you know, at a 1 on a scale of 1, you know, to 10 or 7 in this case, we would start there. You know, that's manageable if it's only a difficulty of 1. And it's something that's likely to lead to some positive outcomes. So we would start there. But as you can see, as you move down here, you know, the eventual goal might be to get up by 8 o'clock or 7:30. And so we're going to move from 9:30 to 8:30 eventually. which for them is, at a level 3 of anticipated difficulty. But we're not going to start there. We start at the 930 and move our way up. Same thing with various categories. So that would be considered kind of routine. But in this example, there are other things that perhaps are enjoyable. So again, maybe spending time with friends is enjoyable. And so they're going to call their friends once per week, while building up to more engaging activities such as, attending a football or watching a football game with friends. It could also be more focused on those valued activities. So in this case, if education is something that the individual values, or getting a job or maintaining a career, we start small with, they're not yet in college, but they really want to work towards getting into college. And so they may work on one college application to help support that goal. But we would have them start to work on one before we actually go into like sending in the applications. So again, kind of that graduated approach. Avoidance modification is another strategy that can be utilized. And here again, we know that people with depression tend to avoid. They feel uncomfortable, they don't like the discomfort, and so they tend to avoid whatever is going to lead to more of that discomfort. And so we teach what we call the trap track model. And I think you heard me mention before that cyclical pattern of getting kind of stuck in depression. So that's what we call our trap. They're kind of trapped in that cycle. And what we do when we look at modifying avoidance is teaching or identifying the function of the avoidance, again with that functional analysis, to help them identify more adaptive ways of choosing to cope with a situation versus choosing to avoid. And we do this again by focusing on more short-term goals rather than long-term goals, just to start at least, with that recognition that those long-term goals might need to be made up of multiple short-term goals before we reach that eventual point. So this is the TRAP model. I apologize if there's any background noise. There's doing some construction in our building, so I hope that's not impacting your ability to hear me. So this is the TRAP model that we teach our patients. And basically, in kind of breaking that down, what we see here is that we have a trigger, and triggers can be, negative, positive, they can be neutral. So it could be, a breakup, it could be a divorce, it could be some significant change in their life. It could be starting a new job, which might be perceived as something more positive. And regardless of what the trigger is, which is not truly the important part of this diagram, they have some type of emotional response to that trigger. And so the response could be emotions that qualify for depression, or they could just be other experiences of maybe more painful emotions or kind of what's perceived to be more negative. But as I said, they also could be symptoms of depression. So, a sense of hopelessness, feeling lonely, feeling neglected, some worry or fear about the future. So might see some anxiety in there as well. And then what happens is we see avoidance. And generally what's happening is that link between the bottom two boxes is more important, to see that it makes sense to avoid those emotional responses. We don't like feeling down. We don't like feeling depressed. Nobody likes feeling lonely or hopeless. And so we generally avoid things, which kind of reinforces that avoidance pattern. And again, the idea here is to explain to patients that their depression makes sense when you look at it contextually. And what we also then see is the more they avoid, so if in this example, let's say they get a new job and that's, a positive trigger, but they're feeling like they have less time to spend with their family, they're feeling more isolated, they're feeling kind of lonely, they're working more hours because they're trying to perform well in this new promotion, and that kind of leads to some depression. And so they may avoid by not really wanting to interact with their family because they don't want to hear their family say, "We never see you." They may withdraw more and just kind of isolate at home. They may stop showing up to work or start to be kind of ineffective at work. And what happens with those avoidance patterns is that triggers more stressful life events. So as you start to avoid performing at work, your colleagues start to question why you got the promotion, and maybe there's some negative emails sent out, or maybe there's some disciplinary action taken, which again goes to these negative emotions and kind of perpetuates that cycle of depression. So we really want to send the message to patients that makes sense as to why they're becoming depressed based on those environmental factors. And then as our means of explaining behavioral activation, we look at what we call getting back on track. So the trigger is still going to happen. The emotional response is still going to happen. We can't change the way we think and when we feel. But what can change is the behavioral response. So instead of avoiding, we would want to encourage active coping. And the main point here for patients to take away is that there are some specific things they can do and that we can do to help them reduce their depression. We also want, our goal should be to kind of diversify and stabilize the available reinforcers in the environment. And the way that this is done is by being more active in how they're responding to those things. And we'll break this down a little bit further, that it's more about actively coping with the trigger as opposed to really the emphasis on the emotion. So routine regulation, I already kind of talked a little bit about. That's another strategy with behavioral activation, which basically just focuses on establishing and following a routine. We know that disrupted routines can maintain depression. And on the flip side, we know that people who maintain routines and stick with routine behaviors usually have better outcomes, and that can actually elevate our mood. With routine regulation, we want to encourage an experimental approach. So, again, with depression, we often see lack of motivation. That won't work. So it's great to encourage, let's just try it. I'm curious to see how you'll respond if we incorporate this into your routine, or if we try to get up just a little bit earlier, if we get up at 9 o'clock instead of 10 o'clock. And again, we do this through activity logs and weekly schedules. And those are generally available. Anybody can look up an activity log for use with a patient, or generating just a weekly schedule to have them outline. We also want a strategy for behavioral activation is attending to their experience. So this recognition that rumination is really common with depression and can actually be another means of avoidance. And something that's a little bit different than with cognitive theories, again, is that we are looking more at the context of the rumination, or this pattern of getting kind of passively and repetitively focused on their symptoms of distress, rather than the content. So there's not as much emphasis on what are you ruminating about. It's kind of more so what led to that rumination. What are you doing, and when you're ruminating, what is it getting you out of doing? Those kinds of things. So we don't really teach about looking for the evidence to kind of like, do you have evidence to support the things you're ruminating on? We really go back more to the context of the thinking and trying to encourage more active means of coping in that moment rather than getting stuck in that cycle. So we incorporate mindfulness into behavioral activation to help improve their ability to attend to those environmental experiences, as well as the activities and behaviors. And then we also want to attend to overcoming obstacles. As I've mentioned a couple of times throughout, these are very severely depressed individuals are very challenging to work with. And so we want to kind of have a preemptive plan of what to do when we are going to encounter these inherent difficulties. So when we're lost in motivation, or we have an individual struggling, my first recommendation is to always go back to ensuring that we've adequately explained the behavioral activation model, that the patient has a good understanding of it, and that they agree with it. If they're not agreeable to trying new things, that's really going to make this whole intervention very challenging. We want to encourage that experimentation, like I said, and curiosity. focusing on kind of suspending their judgments in those moments and, you know, not jumping to this won't work, this has never worked for me before, and really, again, going back to just encouraging, let's just give it a try and see what happens. We want to troubleshoot any barriers. So again, kind of that mental rehearsal that I talked about, as well as being very clear and going through when things are getting in the way, as they inevitably will. Let's talk about how we can mitigate that barrier in order to plan ahead for the next time that we schedule that same activity. We can also do behavior activation assignments right in session. So when we have people who are avoiding, which again, we know is likely to occur if you're assigning them tasks, you can do them right in the session with them. So if they have, you know, a task that they're looking to complete, such as researching jobs, you can pull up the computer and do that right in there with them so that they're not avoiding it and kind of talking through that experience. Really going back to that graded task approach and breaking things down as small as can be. We also want to prepare for the potential for suicidal ideation or increased risk. And we do that by ensuring that we have safety plans in place and that we're regularly assessing for suicide risk, but also linking their goals to things that are kind of considered those protective factors and things that they value. As a means to recognizing that they could choose, you know, suicidal action as a choice or as a behavior that they want to engage in, and they also could choose other ways of responding that might be more in line with their goals. And then involvement of family and caregivers. We know that this supports more positive outcomes when there's support available in the individual's life. And so we want them to be involved in the process as well. We want them to understand the theory and how they can best support the individual in their natural setting. We don't want them having symptoms. We don't want them supporting their depression. We want them supporting the strategies that we're implementing that will get the patient better. So I'm going to go through some examples and more specifics about what we utilize within our individual and group-based treatments at Rogers about how we explain the model to patients. I recognize I only have about 15 minutes left, so I may go through some of this fairly quickly, as some of it is a bit of a repetition. We are big on repetition, though, in behavior activation, so I'm okay with repeating it. So when we're explaining this model to patients, it's really important to ensure that we don't provide this just do it message or make it sound easy. I'm explaining that the theory in and of itself is relatively straightforward, but we don't want to send that message to patients that this is a very easy task. It's not an easy task. We recognize that it's very challenging to start to engage in different behavioral responses when you've been in a pattern for a long period of time. Or it's requiring a change in your response set. And we also don't want to assume that they haven't already tried some of these things on their own. So maybe they've tried to get up earlier. Maybe they've made efforts to kind of do the whole, you know, move your alarm clock across the room, and that just didn't work for them. So we want to validate that they've tried some of these things and that this is going to be a challenge, while also kind of conveying confidence in the model and really emphasizing again that their depression makes sense, and that we know that engaging in activity scheduling can improve their mood and that we're here to support them through that process. We also again want to talk about that graduated approach with that recognition that our expectations are not that you jump to your end long-term goals right away. We're going to take those baby steps to get there. And asking for their reactions and their feedback, allowing them to ask questions. So when we explain the theory to patients, we emphasize more so the link between mood and behaviors. So many of you probably go through like the cognitive behavioral triangle with patients, and it's similar to that. And we can certainly go over that as well. We actually have that in our materials, but helping them see that when you break down our thoughts, our feelings, and our behaviors, what we really want to emphasize is that we see changes in mood when we change behavior. And the way that I like to explain it to patients is kind of like, if we're looking at those three things, our feelings, our thoughts, and our behaviors, what of those three things is the easiest to change? If I just said, you know, stop feeling depressed, change the way that you're feeling right in this moment. That's pretty challenging. If I say, you know, you're thinking negatively, you're thinking that you're not a good person, you're having some self-loathing ideas, just stop thinking about those things. Just change that thought. Again, very challenging. If we say to change the behavior, that's still absolutely challenging, but it is kind of the easier of the three to address. So we kind of take this approach of like, let's just take the easy win, like take the layup, that's okay. We want you to feel some sense of mastery with that versus getting stuck in these patterns or interventions that are more resistant to change. So we go through the TRAP and TRACK model with patients very specifically. We reference this often, and we actually break it down to their own individual experiences. So while this just kind of lays out some examples, we would want to encourage them to try to think about what are some of their triggers, how do they emotionally respond, and how do they avoid. When we explain the TRAP model, it's important to help them see that triggers can vary. They can be negative, positive, or neutral. And again, as I mentioned before, we don't necessarily need to know the trigger. You know, when somebody starts to become depressed, they don't think about it in that moment. They're usually thinking about it after the fact, after it's already happened. So it may be very challenging to identify what kind of triggered that spiral or that change, with the recognition that it could be many small things that kind of collectively come together to contribute to depression. So it's really more important about understanding how our emotions impact our behaviors, and that emphasis on that. This is an actual example that we use with our patients to outline the TRAP and ways to get back on track. So for this example, you know, the trigger is failing an exam and the response is feeling sad and hopeless. If the individual's avoiding things, they would stay in their room, they would sleep a lot, stop studying, not answering, you know, their phone calls or engaging in social support. And that's likely to, again, kind of perpetuate that depression. If they're staying in their room and isolating, they're avoiding more classes, they're failing more tests, so that cycle continues. We want to assist them in getting back on track by changing the contextual factors with that alternate coping. So same trigger, failing an exam, same emotional response of feeling sad and hopeless, but the idea here is that we are responding in a different way. And another point is that the response is actually related to the trigger directly. So rather than the emotion, right? So if they're responding to the emotion, they're going to avoid. That doesn't feel good. That's not as enjoyable to feel hopeless and sad. If they're responding to the trigger by recognizing they failed the exam, they're taking some steps to address that by maybe getting a tutor, finding out if they can do extra credit, finding someone that would study with them. And in response to that, they are likely to feel less depressed over time, because hopefully that positive engagement will facilitate a different response. So that trigger then, maybe hopefully they get a B on their next exam, or they have some improved performance. They feel some mastery over that, and that they did well in that moment, and that reinforces that alternate means of coping rather than reinforcing the avoidance. So we want to outline that TRAP model and really be clear about validating their specific experiences, you know, recognizing that some people's means of coping may look very different, and conveying some empathy in there of, you know, recognizing that this is hard, and we want to, you know, we're here to help you through this and help kind of uncover what's going to be most effective for you. We want to teach these skills using their language and making it very visual. So again, many of our worksheets and visuals kind of contain examples like the one I showed you before, but then have another one with empty boxes that they're able to fill in for themselves. 2 important points. We do want to recognize that everyone's TRAPs and TRACks are going to be different. And so we want to focus more so on what works or doesn't work for that individual, not kind of more generally speaking. We also want to recognize that behavioral activation focuses on the present and not the past. So we know people with depression can get kind of stuck in the cycle of what happened happened in the past or what the trigger is. We really want to kind of shift that focus to like, we are focusing on what's happening in this moment, because your mood is being impacted right now by how you're responding. And if we can change those responses, we can have kind of a meaningful impact on their mood right in the moment. These are some questions that you can ask to help explain the model and get a better understanding of the individual's personal experiences. Again, going back to what are their triggers, what are their specific emotional responses, how do they avoid, when do they avoid, what do they notice when they avoid, getting pretty specific in analyzing those pieces. And then we want to encourage practice activities. So we will do that again, as I mentioned, through a lot of worksheets, questions, assessments that they are completing. So they are completing assignments and homework throughout their time in our program. Every day when they leave program and every Friday for the weekend, they are assigned homework. So the idea is that they're not just doing these activities and understanding these concepts while in treatment. We want that to generalize to their home setting or whatever setting they're functioning within. So we help them do that by completing that TRAP track form to identify their avoidance patterns. We explain to them that we need to know what activities have changed, what have you decreased doing, what have you been, with the goal to help gain insight into those so we know where to kind of start with the activity scheduling. So I talked a little bit before about routine activities, and these are just some examples of those that we can go over with patients. What we actually do is have them complete a routine activity assessment. And again, this is something you could kind of gather like online likely or create yourself to help better understand what does their daily routine look like. We get pretty specific with this. So kind of looking at sleep, for example, what does their sleep look like during the week as compared to on the weekend? It could look very different. Activities of daily living, how many times are they showering? Are they brushing their teeth? Are they doing their laundry? Is someone else doing their laundry? That can give you some insight about potential accommodations that family members might be providing that inadvertently reinforces the depression. Getting an assessment of their enjoyable activities. So what activities have decreased in frequency since they've been depressed? What are they avoiding doing? And we kind of break that down through an enjoyable activities list that they can develop. And again, you can find those online as well, which just gives you an idea of having them assess what did they used to do that they don't do anymore or that they don't currently enjoy anymore. What activities are they currently doing that they enjoy a little bit to make them feel slightly less bad? And what are some activities that maybe they thought that they might enjoy but just haven't really tried yet? And that again gives us some starting points in that graduated kind of assignment and that hierarchy of what we can move towards. And this is just an example of an activity list. I do want to make the point about enjoyable activities that can also function as avoidance. So here this goes back to your functional assessment. There may be many activities that people enjoy, such as watching TV or playing video games. But if they are doing those activities in excess, if they're playing video games 10 hours a day, that's likely to be more a function of avoidance than something that they're really enjoying. Our adolescents like to talk about that and say, but I really enjoy playing, video games. And I even am doing it online with people and socializing. But again, if you're doing it in excess and it's preventing you from following through with other tasks or responsibilities, we would not qualify that as an enjoyable activity. Some activities they enjoy could even be harmful to them, such as substance use. And so obviously we would want to work towards limiting those and setting some guidelines with those activities. So some ways we can do that is by setting reasonable time limits for the activity. We can also combine the strategies of setting time limits as well as goals that they have to meet, or consider cutting an activity altogether. The last point I just want to get in is that of values. So values are a really important piece, and we want to go through the values assessment form in order to help an individual really understand what things do they value in their life, what do they find meaning in, because we know when somebody finds more meaning in an activity, So this is an example of one of our value assessment forms that helps break down the valued category, what type of person they want to be in that area, as well as how they've been doing with that in the last month. And when they can see those discrepancies, that helps them to set some very specific and measurable goals of what they want to achieve and what they want to work with while they're in treatment. Are you guys okay with me continuing, or would you like me to stop just because we're recording this?
I'm fine with you continuing.
Yeah.
Okay, I only have a couple more slides, so
Sure.
That's fine.
Sure.
So this is just some examples of behavioral activation assignments that are based on values. So if an individual identifies that, you know, family relationships are really important to them, we might set a very specific goal of calling their mom 3 times a week, talking for 20 minutes each of those times, and ensuring that the topic is not about their symptoms or their treatment. So really working on building that relationship with the parent versus getting stuck in a cycle of needing them or needing to talk about what's going wrong. You know, if they value, again, education, you know, we might set that goal of working on college essays for 20 minutes a day for 3 days in that week. And here we come back to those SMART goals of being, again, very specific, measurable, appealing, realistic, and time-bound as far as how they're setting themselves up. We want to set them up for some success and to gain that sense of mastery and achievement that's also in line with things that they've identified that they value. Patients often ask, why do I have to schedule all these activities? Why do I have to fill out all of these forms? And so it's really important to help review with them that the goal is to increase their engagement in these activities at a somewhat challenging but manageable rate, and that we know that over time this is likely to get easier. At some point in their life, we hope that they don't have to write them all down, but right now that's what they need to help support their recovery and their improvement in their depressive symptoms. We also need to emphasize that scheduling activities is important because through repetition, we come to kind of inherently engage in these activities, develop that routine, and it again becomes easier for them. So we want to be specific about our goals and how that relates to the use of behavior activation. So this is an example of a weekly schedule that we might create for patients. This is usually comes off of behavior activation assignments that they were given. So for example, if their assignment was to research recipes, and let's say one of their long-term goals is to be, you know, to cook more regularly or to expand their appetite, expand their engagement with family members through having family meals. Their assignment may be to start researching some recipes that they're interested in. And then when we shift to their weekly schedule, we would actually help them in breaking down that goal. So maybe Monday they research the recipes. Maybe on Tuesday they pick one of those recipes that they're interested in making. Maybe on Wednesday they create the grocery list for those items that they need. On Thursday, they go to the grocery store, and on Friday, they actually cook the meal. So again, that's an example of really breaking down those assignments, but being really clear in how that goal relates to their values or some of their longer term items on their list. It's helpful to change things up and to work on modifying their behavior activation goals, and this weekly schedule gives us an opportunity to review that. Focusing on the things that have gone well for the week and maybe things that were really challenging for them. And then, as I said, we help them create that weekly schedule and be very clear about checking those things off, or really giving some attention to things that they are not finding they are able to check off. Some additional components of our program that we teach with patients. So what I honed in on was more so the psychoeducation that we provide to our patients, the way that they can monitor their symptoms, and then how we actually support them in scheduling activities. We also in our programs teach psychoeducation about other topics, so including more generally about anxiety and depression, obviously about activity scheduling and monitoring their own symptoms, so being attentive to like their rumination, their isolation, and trying to work to reduce those avoidance patterns. We talk about mindfulness a lot. We generally do that on a daily basis, and we encourage practice of mindfulness outside of our setting. We also teach how to set goals and how to problem solve. So breaking down those elements so that the patients feel more capable of utilizing those skills in the moment. We also teach communication skills with the recognition that, you know, we are social beings and we have to involve with others to help support their progress and support these interventions. So we work on, you know, teaching assertive communication and strategies for trying to work together with others. We use a lot of motivational interviewing to help recognize kind of where they are in that change process and how to get them moving along that continuum. And then weekend planning is another one that I mentioned previously, in that we are very intentional about setting them up for continuing to utilize these skills throughout not only the week and their time in treatment, but also after treatment and on the weekend, really kind of viewing the weekend as a way, as a time to kind of show us what they've learned throughout the week and identify the barriers as well, and be really specific about what we need to keep working on to support their progress. Lastly, generalizing behavior activation is really important and kind of builds off of that weekend planning idea. We want to encourage the use of activity schedules at home and at school. For those of you who maybe are teachers or kind of in an academic setting, you know, there are ways that behavioral activation can be reinforced within a school setting, with that focus on goal setting, being very clear, breaking down a schedule of when tasks and assignments are due, helping to problem solve those barriers, using mindfulness before starting the school day or before switching tasks, and really supporting active coping over avoidance. And again, generalizing through that teaching of functional analysis to patients and caregivers so that they can engage in that task with some level of independence. And creating and maintaining those relapse prevention plans, being willing to share those with others. So maybe sharing them with teachers if they're in an academic setting, or with their spouse or their family members, so that they know how to best support them in really solidifying those skills in the natural environment that they're likely to transition to. So that brings me to the end, and I don't know that we have time for questions, but I'm happy to answer any if there are some. I'm also willing to answer them via email if you guys have any questions after the fact that you'd like to send me.
Thank you so much for being here with us today and doing this presentation for us. That was great.
Of course, thanks for having me.
Yeah, thank you. There was a question, I don't see it now, about some of the alternative treatments that are coming out for treatment-resistant depression, like ketamine or psilocybin. Wondering if you have any thoughts on that?
You know, at this point, that's not something that we're specifically incorporating at Rogers, though we are very attentive to research and always willing to incorporate elements that will help improve the outcomes for our patients. We, you know, work with a multidisciplinary team, so it's not uncommon for us to incorporate different pieces to an individual's treatment. You know, everyone has a psychiatrist that they're meeting with regularly, and so if there are, you know, if there is research to support trialing different medications, the psychiatrist works very closely with the patient and the family to support that, as well as accessing other programming throughout Rogers that might be maybe more beneficial or incorporate some of those updated treatments.
So are you worried that because these are available to people to go outside of their providers and do these therapies themselves, so like ketamine, for example, is available to Milwaukee residents, it's something that you can go and do, pay for by yourself, it's not covered by insurance, so, you know, like, it's not, I guess, a medical procedure per se.
Mm-hmm.
But people are going to go and try these things because they think they're going to fix them. Does that concern you at all with, you know, like what you're doing to treat them already?
Yeah, I mean, I think that we would We would hope that we would be able to have an open discussion about that if they're not feeling like their treatment is effective in that moment, that they're having to utilize kind of these external resources, and might ask that they kind of hold off on implementing other things that are not really following our treatment protocol. That being said, you know, if an individual is truly motivated to do that, I think it would be appropriate to kind of review the risks and benefits. We use what we talk about as a cost benefit analysis within our treatment. And so that could be something that we would maybe break down for them about the costs and benefits of it, as well as kind of identifying what are the costs and benefits of doing that now while you're already receiving a treatment that has some efficacy and validity to it, versus maybe waiting to see, like, let's give this treatment a fair shot, see what happens, and then from there we can kind of visit that option. So again, it would be kind of encouraging that open dialogue and communication with the multidisciplinary team to ensure that hopefully those variables aren't happening without our awareness.
Thank you.
Sure.
Any
other questions?
All right, well, this will conclude our virtual presentation on depression. Thank you for your clinical view and the opportunity to work with you, Dr. Roberts.
Of course, thank you so much.
Yeah, thank you all for coming. And this concludes our we will record this and we'll make it available on NAMI Racine's Facebook page and website. And Dr. Roberts and Alyssa, we can also share that link with you so that you can share it with your Rogers networks as well. So thanks very much.
Excellent. Thank you so much.